Hi, my name is Rick Bransford. I'm the current Orthopedic Fellowship Director for Spine here at the University of Washington Medical Center. And I just want to take this opportunity to give you a little bit of a rundown on sort of our system, so that as you contemplate coming here for an interview, or if when you do come here for an interview, you have a little bit of a perspective on who we are, what we're doing, and potentially consider if this is the right place for you. So as I mentioned earlier, my name is Rick Bransford. I've been here for over 25 years here now. I did my residency here, and I've been on faculty around 19 years now. The other main orthopedic spine colleagues are Carlo Villabarba, who's been here since the late 90s. He's the current Chief of Orthopedics here at Harvard Medical Center. And then there's Viral Patel, mainly based at the University of Washington and Northwest. He's been here the better part of about 5 years, and then Haitao Zhou, who's based here at Harborview as well. There are also other neurosurgery spine surgeons as well that you would have the opportunity to work with. The busiest one is Fengyi Zhang, who's based here at Harborview, does probably close to 400 to 500 cases a year. There's Christoph Hofstetter, who specializes in endoscopy. There are people over at the university as well, but the main people would be the four of us who I mentioned at the start, who've been here for between 5 and 20 plus years here. One of the questions that frequently comes up is sort of what is our breakdown in terms of volume, and as a system we're doing well over 2,000 spine cases a year, so lots to pick and choose from. We are the referral center for the entire Northwest. We're the only level 1 trauma center in the area as well, covering a 4 to 5 state area, so lots of opportunities here. I think one of the misconceptions that frequently comes up about us is that if you come to the University of Washington / Harborview, all you will do will be trauma. And certainly it is an area we specialize in, but when we actually ask our fellows to look at the breakdown of the cases they do, truly only about 15 to 18% of those cases end up being trauma cases when you look at it from a number standpoint. Certainly there's lots of exposure with sign-out rounds, and you will know very well how to manage trauma, but certainly it will not be all you will do when you are operating here as a surgeon. We also, being the referral center, get the complex deformities, we get the metastatic tumors, some primary tumors, we sort of get the redo, so a lot of revisions, but equally to balance it out, we get the microdisc, the single level ACDF, the simple laminectomies, so really get the whole gamut of pathology, from the degenerative to the deformity, to the tumor, to the trauma, and really I think when people leave here, they really leave here prepared to essentially tackle anything from occiput to sacrum, anteriorly, posteriorly, you name it, you should be prepared to do it. So I think one of the things we really want to sort of try to demythify is the fact that yes, we are a trauma center, but given the number of surgeons here and only one of us is on call at a time, there's certainly plenty of opportunity to do things outside the scope of trauma, and again really breaks down to about 15 to 18% in totality when we look at it by volume. The main hospital is Harborview. This is where at any given time, right now we have 4 fellows. We typically have 3 a year, but 2 to 3 of the fellows are based here at Harborview. There is one that will float between the university and Northwest, but this is sort of the mothership, if you want to call it that, in terms of where you will spend the bulk of your time. The average breakdown is 3.5 days in the operating room, 1.5 days in the clinic. We try and balance that out. You will run a clinic independently for about a third to quarter of your fellowship, but really feel that that's an important part of training, is not only to know how to operate, but what to operate on, and equally to see post-ops, to see how they are doing, to discuss indications, to sort of use that as an opportunity to learn. And I think that most people feel that that balance is pretty adequate. We are an AO site. As a result of that, you get the privileges of AO fellowship, and what that means is that there are webinars, there are opportunities to go to a fellows course in usually late August, early September for a 3-day cadaveric course. There's also the option of going to Banff for 2 or 3 days in March or April, and these are all kind of encompassed in the AO fellowship site. There are usually about 100 AO fellows countrywide. Again, gives you opportunities for webinars, for interaction, and for these things as well. Besides the fellowship course that all of our fellows get to go to, that's a 3-day course, cadaveric and some component of practice management. BAMP is really largely revolved around networking. There is some component of case discussion, but also you will present research that is done there, and I'll get to that a little bit later. But your ticket to get there is you have to have a research project to get there. So there are research presentations, but a lot of it is networking as well. Besides those things, we also fund you to go to either the AAOS, CSRS, or NAS. We only want 2 fellows gone at a time, so between those ones we kind of leave it to you all to figure out who's going to go to what. We will pay your way for that, we'll pay your registration, we'll pay for your hotel, so that is all covered. Besides that cost, we will also cover the cost of a set of loops to a reasonable amount, up to about $2,000. We'll also buy your lead for you while you're here, so there are some benefits to that we will provide during your fellowship here as well. As I mentioned earlier, being an AO site, the only way you can get to Banff is to do a research project. We highly encourage, although we do not insist, that everybody do a research project. We do have support in place to do that. We have a research coordinator, we have a statistician, we have a fairly robust database. We are currently implementing sort of prospectively gathered PROs, so a lot of data in place. We have provided a PDF that you can look at as well, and within that you can see the various topics that we have published on in the past to give you a bit of a perspective of sort of the projects that fellows have been a part of that maybe will give you some guidance in terms of what would be realistic in terms of what you can accomplish. I think we sort of ask most of our fellows to not get involved in sort of prospective type studies, as these are not easily accomplished in a year. We want you to have something that you can really largely do in the first 6 months or so of your fellowship, so that then you have something ready for Banff. In terms of an academic program, we do provide a fairly robust academic platform for learning. We have journal clubs that are usually once a month. Those are sort of a citywide type journal club. We also have a lecture series that usually led by Carlo Bellabarba that are done on Thursday morning from 7:30 to 8:30. He tries to systematically go through trauma from occiput to sacrum, go through deformity and principles, go through degeneration, go through principles of implant placement, sort of the whole gamut of stuff, and collectively that adds up to about 40 hours of academic lecture slash discussion, if you will. We also have a weekly meeting with our neuroradiologist. That's on Thursday morning from 8:30 to 9, where we meet with our radiologists, discuss interesting cases. We get their input on what they're looking for on certain films. We discuss cases that we don't necessarily know the answer to, so kind of a nice opportunity to interact with our neuroradiologist and get some of their understanding as well. We also have a Friday morning conference from 7:15 to 8 o'clock or 8:15, where we discuss all the cases coming up in the coming week. So kind of a good indications conference to discuss, one, to ensure that we've addressed all the nuances of particular patients, that as we look at images collectively that we haven't missed something on those films, but also again kind of gives us a good platform to discuss evidence-based medicine. Once a quarter we will also do a M&M where we'll discuss complications and sort of talk about those, how they could have been avoided, and use that as a platform there as well. So through the week we end up having about 3 hours of academic slash evidence-based medicine type discussions outside of the normal clinical array of being in the operating room and being in clinic. I think one of the issues that some people are concerned about is with 3 fellows, how do we make all that work? Do people kind of get cut short in terms of what they can do? Most days there's usually at least 2 or 3 operating rooms running. There's usually at least 1 or 2 clinics running. So I think the way we look at it is, with over 2,000 cases being done per year, there's no way that even 3 fellows can really absorb all that. And so it's really between the fellows to decide. You will have certain rotations during your fellowship, but then you can decide between 2 rooms or 3 rooms. You know, I've done a bunch of this case, but not a lot of that one. Let's kind of flip-flop that. But there's really, even with the with 3 fellows, there are cases that go uncovered by particular fellows, just due to the magnitude and the volume of stuff that goes on here. Again, as we kind of look at it, I think most people leave here very prepared to go out into practice. Probably about half to 2/3 of our fellows end up going into private practice. The other third to half will go into academics. We are indifferent to sort of what you want to do when you leave our fellowship. That's up to you. What we have found is that regardless of where our fellows end up going, is that ultimately they become rapidly the go-to person because they are facile, they're comfortable dealing with everything, and so they are not sort of a one-trick pony or only do deformity or only do degen, that they really can do it all, again, whether they're in academics or private practice. We've had a fellowship here for at least 25 years now. I think the first fellow was maybe in '93, so I guess that's closer to 30 years here. We've had 2 fellows since the early 2000s. We've had 3 fellows since the late 2009, 2010 sort of era. So we are well established. I think that our volume is predictable. We are looking to potentially grow by another surgeon within the next year or two, so that's sort of open-ended for the time being. In terms of the stability of our faculty, we don't really have anybody who's looking to retire or slow down to the best we can determine anytime soon. So I think the fellowship is not at risk of sort of falling apart. And again, having said that, even if it were, the volume will stay the same just based on our regional location and where we are getting referrals from and the patients coming to us based on being the only referral center or tertiary referral center for the entire region, as well as the only level 1 trauma center. So hopefully that gives you some perspective on our fellowship, who we are, gives you a platform to determine if you are interested in coming here to do an interview, and if you are coming for an interview, give you a platform on which to sort of base some questions moving forward. So hopefully that's helpful. You will also have access to a PDF that discusses a little bit more in a paper format, sort of the nuances of what I've just discussed, as well as some of the papers we've written, book chapters, papers we've written in the last 5 or 10 years that give you a bit of a perspective on who we are academically. So hopefully this is helpful, and hopefully talk to you soon.